Hello, and thank you for asking me to speak at the 17th Delta Gynae Cancer Symposium. Over the next 25 minutes, I hope to be able to update you on the impact of obesity on our patients and ways in which we can look to tackle this, from prevention through to endometrial cancer treatment and survivorship. So why are we, as individuals who look after women with obesity, with endometrial cancer, so interested in obesity? Well, that's because it's a significant risk factor for the disease, and in fact is the leading modifiable endometrial cancer risk factor. The two heat maps shown here clearly demonstrate how, as the percentage of the population with obesity increases, illustrated by these darker shades of red, so the age-standardized incidence of endometrial cancer also increases, with corresponding areas of high incidence shown in dark blue. I think it's important to appreciate that obesity and endometrial cancer are no longer diseases of high socioeconomic index nations, but are now global conditions, with the greatest increases in endometrial cancer incidence over the last 30 years being in the high-income Asia-Pacific, North Africa, the Middle East, and southern sub-Saharan Africa. This is thought to be due to the adoption of more westernized lifestyles and increasing obesity prevalence in these countries. How strong is the link between endometrial cancer and obesity? Well, obesity has the strongest link with endometrial cancer of the 20 most common tumour types, with overweight and obesity thought to be directly causative in up to 41% of endometrial cancer cases. Meta-analysis of observational studies found that for every 5 kg per metre squared increase in BMI, the risk of endometrial cancer increased by 54%. The effect, however, is non-linear, with the risk increasing markedly in individuals with BMI greater than 25, such that a woman with a BMI of 40 has a 10-fold increased risk of endometrial cancer than a woman with a BMI of 20. This equates to a lifetime risk that exceeds 10%. How does obesity cause endometrial cancer? Well, it acts through 3 distinct but interrelated mechanisms, namely excess estrogen exposure, insulin resistance, and inflammation. Adipose tissue produces the enzymes aromatase and 17-beta-hydroxysteroid dehydrogenase, and it's these that are responsible for the conversion of androstenedione and testosterone into estrone and estradiol, respectively. Hyperinsulinemia also leads to a reduction in sex hormone binding globulin levels and hence an increase in the proportion of bioavailable estrogen. Estrogen, in the absence of counter-regulatory hormone progesterone, stimulates endometrial cell proliferation and inhibits apoptosis. And this uncontrolled cell turnover increases the risks of cells accumulating cancer-causing mutations. Obesity is also associated with the development of insulin resistance and chronic hyperinsulinemia. Both insulin and the related hormone insulin-like growth factor, or IGF-1, have a direct effect on the endometrium, driving cell proliferation and survival through activation of the insulin receptor. These effects are mediated through both the PI3K, AKT-mTOR, and the MAP kinase pathways. Hyperinsulinemia also increases ovarian androgen production and its peripheral aromatization to estrogen. This also explains the link between diabetes and endometrial cancer development. Thirdly, expansion of adipose tissue and its subsequent hypoxia initiates the secretion of pro-inflammatory cytokines, creating an inflammatory environment. These cytokines act through the NF-kappa B pathway to inhibit apoptosis, override cell cycle arrest, and increase the transcription of further cytokines, leading to a vicious inflammatory cycle and tumorigenesis. Inflammation also promotes insulin resistance, and IL-6 stimulates aromatase activity and the conversion of testosterone into estrogen within the adipose tissue. Knowledge of these mechanisms is important as it can be used to generate novel endometrial cancer prevention and treatment strategies. Whilst obesity is a strong risk factor for endometrial cancer, it's not the only risk factor, and indeed not everyone with obesity will develop the disease. If clinical trials to identify potential prevention strategies are to be conducted, and particularly if these interventions are then going to be rolled out into routine clinical care, then more sophisticated means of identifying high-risk individuals are needed than simply relying on measurements of BMI alone. We have recently published the Precision model, an endometrial cancer risk prediction model that was designed specifically for use in UK women aged 45 to 60 years. The model was developed within the UK Biobank dataset and includes these 12 easily measurable predictors as shown here. They're all based on information that women will know about themselves or can be extracted easily from primary care medical records. The model, whilst heavily weighted on BMI, also takes into account reproductive variables, the presence or absence of diabetes and hormone use, as well as age and family history. External validation of the model within GP records has shown that it accurately predicts how likely a woman is to develop endometrial cancer within the next 10 years. Importantly, use of the model appears to be associated with greater net benefit across a range of risk thresholds than other previously published models, or the alternative strategy of offering endometrial cancer prevention to all. Endometrial cancer, with its close association with modifier risk factors, is eminently suited to primary disease prevention, with modelling suggesting that up to 60% of endometrial cancer cases could be potentially prevented. This remains, however, a largely under-researched field, with only 3 RCTs conducted to date, all of which were too small and had too short a follow-up period to comment on the effect of their intervention on endometrial cancer incidence. The majority of the evidence to support potential prevention strategies is therefore based on data from observational studies. Weight loss appears to be associated with reduction in endometrial cancer risk, with loss of as little as 5% body weight shown to be associated with a significant benefit according to the Women's Health Initiative study. Whilst women with obesity derive the most benefit, even those with a BMI within the normal range at study recruitment also benefited from weight loss of this magnitude. The weight loss works by reducing both the mass of adipose tissue, but also improving insulin sensitivity. The difficulty with aiming to lose weight through diet and physical activity, though, is that it's difficult to maintain this weight loss in the longer term, with weight cycling having an even more detrimental effect on endometrial cancer risk than having a persistently elevated BMI. Weight loss secondary to bariatric surgery is often greater and more likely to be sustained, with a meta-analysis suggesting a 62% lower endometrial cancer incidence for women undergoing the procedure compared with women with obesity who had not. Bariatric surgery is not without its risks, though, and women need careful counselling about the dramatic change in eating patterns that are needed following the procedure. Increasing physical activity appears to have a beneficial effect on endometrial cancer risk, but with women needing to undertake at least 7 hours of jogging per week for a 10% reduction in cancer risk to be realised, it's unlikely to be a realistic prevention strategy for the majority of women. Users of the Mirena coil have been shown to have up to a 78% lower risk of developing endometrial cancer than women who've never used it for contraception or abnormal uterine bleeding, and the coil acts to counteract the effects of estrogen on the endometrium. The benefit appears to be greater the longer the coil is left in. Whether women who are at high risk of endometrial cancer would derive a similar degree of benefit from using it, and if losing weight simultaneously may make the coil work even better, is something I'm hoping to evaluate within a feasibility RCT in the near future. So as well as increasing the risk of endometrial cancer, obesity also impacts upon diagnosis of the disease. Whilst the majority of cases of endometrial cancer are diagnosed in women in their 60s and 70s, there is an increasing proportion of younger women being diagnosed with the disease, with up to 30% of women under the age of 50 at the time of diagnosis, certainly within the USA. And premenopausal women are not considered within the suspected cancer guidance from NICE, and as such, health professionals in both primary and secondary care need to have a high level of suspicion for endometrial cancer in women with persistent, irregular or heavy menstrual bleeding in combination with obesity, PCOS or diabetes. Performing a vaginal examination and endometrial biopsy can be challenging in this patient group. Use of a longer Winterton speculum and colposcopy couch may aid visualization of the cervix. Alternatively, the left lateral position can be used. Hoist transfers onto the couch may be required for women with limited mobility. The low upper weight limit and restrictive diameter of some particularly older MRI scanners can make it difficult to stage women with obesity and endometrial cancer. Open machines, such as the one shown here, that's based at Manchester Airport, can help circumvent this problem. Alternatively, a CT scan of the chest, abdomen, pelvis, whilst less sensitive in detecting myometrial invasion and lymphadenopathy, can be used to exclude distant metastatic disease. Although the mainstay of endometrial cancer treatment is surgery, this can be technically challenging in women with obesity. Minimal access routes offer the advantage of less blood loss, shorter hospital stay, lower infection rates and less post-operative pain compared with open hysterectomy without compromising survival. Robotic surgery has the advantage over straight stick laparoscopy of being associated with lower rates of conversion to an open procedure for women with a BMI of 40. Meta-analysis has suggested that this was largely due to a lower rate of conversion because of intolerance of the Trendelenburg position by anaesthetised patients, presumably because lower pressures are being used to maintain an adequate pneumoperitoneum. Use of the robot is also associated with a lower risk of organ or vessel injury, again because of improved visualisation of the anatomy. The benefit for patients is a shorter hospital stay, and for the surgeon a more ergonomic procedure with less muscle activity. Whilst the cost of purchasing a robotic platform and consumables has traditionally been considered prohibitive to NHS trusts, this argument's weakening with increasing patient complexity and this cross-specialty use of equipment that we often see. If open surgery is planned, then consideration should be given to performing abdominoplasty at the same time in order to improve access and reduce the risk of wound infections. Vaginal hysterectomy is certainly an option for people that are unfit for an abdominal procedure and who have localized disease. In order to reduce the risks relating to endometrial cancer surgery for women with obesity, a thorough preoperative assessment is mandatory. This includes risk assessments for sleep apnea and cardiac failure and potential review in an anaesthetic clinic. High dependency monitoring may well be required for the immediate post-operative period. Within the confines of cancer targets, prehabilitation should be considered to try and reduce the morbidity associated with surgery for women with obesity. The Prehab for Cancer programme in Greater Manchester is an award-winning prehab programme that offers tailored advice to individuals awaiting cancer surgery and focuses on diet, physical activity and mental well-being, and includes access to dedicated fitness instructors and community leisure facilities to improve cardiorespiratory fitness. Engagement with the programme has been shown to reduce the length of hospital stay, perioperative complications, and improve physical function in patients undergoing colorectal surgery. We're currently discussing with the team behind the programme about extending it out to our gynae cancer patients. Experienced anaesthetists are required in order to anaesthetise women with obesity, as high airway pressures generated by the steep Trendelenburg position need to be tolerated, and overventilation of women towards the end of the procedure is needed to combat the hypercapnia that otherwise develops. Adjuncts for positioning patients safely are essential, including beanbags to ensure that patients remain static on the operating table and don't slide, and hover mattresses to enable safe transfers. Extra long ports may be required to ensure that the instruments are able to extend into the peritoneal cavity. Planning and delivering radiotherapy in women with obesity is also technically challenging due to greater daily shifts and larger errors. As shown here, systematic errors in the longitudinal and vertical directions are positively correlated with BMI. This means that it's harder to target the radiotherapy beam in women with obesity, putting non-involved tissues at greater risk of damage, increasing the risk of treatment-related side effects. Primary radiotherapy remains a reasonable alternative for medically inoperable patients, with median progression-free and overall survival of 43 and 47 months respectively within observational studies. Recurrence rates are higher than after surgery, but are likely to still be less than 16% at 5 years. Combination of external beam and brachytherapy has been shown to be more efficacious than either modality alone, if it can be tolerated. Importantly, this group of women have a 3.4 times higher risk of dying from other non-cancer causes than they have from dying of their endometrial cancer, and this is an issue that we will return to shortly. Medical management of an atypical endometrial hyperplasia and low-grade endometrial cancer with less than 50% myoinvasion is an option for women who are either medically unfit for surgery or those who decline hysterectomy because of a desire to preserve fertility. Intrauterine progestations are associated with similar rates of disease regression as oral progesterone, but are better tolerated with fewer side effects and hence improved compliance. In Manchester, all women undergo a baseline endometrial biopsy and have an MRI scan that is reviewed at our Gynaecological MDT in order to confirm eligibility for medical management. Women with a BMI greater than or equal to 35 are also offered expedited bariatric surgery through the Salford weight loss team. This is either a sleeve gastrectomy or a laparoscopic gastric bypass, depending upon patient preference. Those who decline or have a BMI less than 35 are encouraged to lose weight through a low-calorie diet of their choosing. The 12-month target is weight loss exceeding 10% body weight and or an end-of-treatment BMI less than 30. Repeated endometrial biopsies are performed at 3 monthly intervals and MRI scans repeated at these time points for women with endometrial cancer. At the end of 12 months, the Mirena coil is removed and a repeat endometrial biopsy and MRI scan are performed. A further endometrial biopsy is then performed again after a 6-week washout period to confirm disease response. This is defined as either complete if both of these end-of-treatment biopsies show no hyperplasia or malignancy and the 12-month MRI scan is normal, or partial if there is a substantial improvement in endometrial morphology and a normal MRI scan. Stable disease is defined as similar findings on post-treatment biopsy and scan to those present at baseline, and progressive disease as worsening endometrial morphology or MRI features. Women with stable or progressive disease are often hysterectomy, with or without conservation of the ovaries in premenopausal women. And for women who've had a complete response and previously suffered from infertility, a referral is made through to the reproductive medicine department for assisted conception. All women are offered hysterectomy at the end of treatment or upon completion of their family, if at all possible. For those who decline or remain unsuitable for surgery, the Mirena coil can be left in indefinitely, with 3 to 6 monthly and then annual surveillance endometrial biopsies up to 5 years. Based on our local data in Manchester of 71 women who've been followed up for a median of 40 months, 61% have demonstrated treatment response to the Mirena coil, with 7% progressing whilst on treatment. 5 women, which equates to 7% of the cohort, recurred after initial treatment response. One of these women subsequently underwent a hysterectomy, and the remaining 4 recurred with atypical hyperplasia, which was successfully managed with reinsertion of a Mirena coil. Of 6 women who attempted pregnancy, 1 live birth has occurred to date. Multivariable logistic regression has identified that women with atypical hyperplasia and those who've lost 10% or more of their body weight over a 12-month period have got a significantly higher chance of responding to the Mirena coil at that 12 months. And these findings are in keeping with those of the Australasian FEM study. Realistically, in our series, this means that women undergoing simultaneous bariatric surgery were much more likely to respond, as 86% of women in that group had lost more than 10% of their body weight, compared with only 23% of those employing a low-calorie diet. Establishing the links with the local weight loss service ensures that our women are promptly reviewed in their clinic and have a fast track to weight loss surgery without having to undergo the otherwise rather lengthy preoperative assessment process. Obesity not only impacts upon endometrial cancer treatment, but may also influence survival. And there's debate within the literature as to whether women with obesity have poorer survival after a diagnosis of endometrial cancer than women without obesity. Suboptimal treatment may play a role, as post-hoc analysis of data from the MRC Aztec trial failed to show any difference in survival between women with and without obesity when they receive the same standard of care. Instead, it may be that women with obesity are at an increased risk of dying from other diseases. My group has recently performed a systematic review and meta-analysis of the cause of death of women following an endometrial cancer diagnosis, finding that women are twice as likely to die from non-endometrial cancer causes, as shown here in yellow, than they are to die from their endometrial cancer, as shown in blue. And this is particularly the case if women had low-grade and low-stage disease at diagnosis. Over 25% of these deaths related to cardiovascular disease, which is perhaps not surprising given the number of shared risk factors for the two diseases, including obesity. Cardiovascular deaths overtook deaths related to endometrial cancer between 5 to 10 years after diagnosis. We've previously shown that women treated for endometrial cancer in Greater Manchester have a significant number of undertreated and undiagnosed cardiovascular risk factors, and we've now begun to try and optimise these within our endometrial cancer follow-up clinics in the hope of improving cardiovascular disease risk and quality of life. And this is the aim of our Optimus study. Women have been encouraged to lose weight, increase their physical activity levels and improve their blood pressure, cholesterol and diabetes control in consultation with their GP, using recommendations based on NICE guidance. Of 56 women who've completed 12 months of follow-up, 25% have made more than 50% of the changes recommended to them, with a further 20% making some but not quite half of the recommended changes. Compared with women who made no changes, who actually gained half a kilo in weight over the 12 months, women who made any of the changes lost on average 3.4 kilos in weight. They increased their physical activity levels, they reduced their HbA1c and improved their liver function, in keeping with improved control of metabolic syndrome. While there's been no corresponding improvement in Q-risk-3 score, a widely used measure of cardiovascular disease risk, this may well be because the Q-risk-3 score is heavily dependent upon age, and these women were a year older at the end of the study than they were at baseline. The fact that their Q-risk-3 score hadn't increased as it did in the group who'd made no changes is suggestive of at least some degree of improvement in cardiovascular disease risk. Cardiovascular risk factor optimization may also improve quality of life. There's been insufficient high-quality evidence to determine whether weight loss interventions alone are associated with improved quality of life in endometrial cancer survivors, but we have been able to show within Optimus that BMI is an important independent predictor of quality of life, along with ethnicity and socioeconomic deprivation. Women who made over 50% of the changes recommended to them within the Optimus study benefited from improved physical functioning and less pain on their SF-36 quality of life questionnaires, potentially helped by the weight loss experienced. Ongoing analysis of qualitative interviews undertaken with a subgroup of women participating in the study will hopefully shed light on the barriers to engaging with lifestyle modification and optimization for risk factors for cardiovascular disease. We're also hoping to begin offering women a tailored physical activity programme with small group classes and free access to community leisure facilities in Greater Manchester to see if this encourages engagement with the programme. So in summary, obesity and endometrial cancer are strongly linked with extensive epidemiological and laboratory data to support a carcinogenic effect of obesity on the endometrium. Weight loss through changes to diet and physical activity could play a role in primary endometrial cancer prevention, but its efficacy within a high-risk population is currently unknown and is the focus of future clinical trials. Diagnosing and treating endometrial cancer in women can be difficult if they have obesity, and a high index of suspicion is required to prompt an endometrial biopsy in younger women who have abnormal bleeding patterns and obesity. And clinicians may need to be creative in how they adapt their clinic rooms and theatres to manage the unique challenges posed by this patient population. Unfortunately, as rates of obesity increase, so the complexity of our cases will also rise. Minimal access surgery, particularly robotics, offers many advantages to women with obesity and their surgeons, but needs a whole team effort to ensure its success. Non-surgical treatments, including primary radiotherapy and medical management, have a role to play in women unfit for or who decline surgery, but are associated with higher rates of recurrence. Insertion of marina coil buys time for women to undergo weight loss surgery, which would increase both the effectiveness of the intrauterine progesterone, as well as improving fertility rates and optimizing women for later surgery. Obesity appears to impact upon survival after a diagnosis of endometrial cancer, but may well do so through increasing the risk of death from cardiovascular disease rather than a direct effect on the risk of disease recurrence. It's also a significant negative predictor of quality of life. A diagnosis of endometrial cancer represents a potential teachable moment for women who have often had lifelong weight issues, and women are receptive to receiving lifestyle advice and to commence drug therapy to reduce their cardiovascular disease risk. Tailoring survivorship programs to the needs of this group will hopefully encourage long-term engagement and improve survival and quality of life for all. I'd just like to thank the members of Team WOMB, including Professor Emma Crosby, Dr. Heather Agnew and Daisy Bedell, who've contributed to a lot of the work discussed here, to the team involved in developing the precision risk prediction model, and all the women and their families that are involved in our studies. I couldn't do this without the support of the Rosetree Foundation, the NIHR, and well-being of women who've sponsored much of my work. Thank you.